Assalamu alaikum, hayakum Allah jami'an. Now we'll move to the third lecture. We'd like to thank first Dr. Angela, and we'll move to lecture by Professor Hazem Alkhawashki. He is a consultant. Professor Hazem Alkhawashki is a consultant orthopedic surgeon, well known to all of us. He's the former president of Saudi Orthopedic Association, and he is a member of Saudi Osteoporosis Society. So welcome, Prof. Hazem.
Thank you. Thank you. Well, I would like to thank the organizing committee for inviting me. A lot of the points that I'm going to mention has been touched by the previous speakers. Now, osteoporosis, we all know that it's a global silent disease, and usually you don't discover it until maybe it's caused a fracture. And we in Saudi Arabia have actually more of the, prevalence in Saudi Arabia is more than the world and Europe, both in males and in females. Burden also of the disease of osteoporosis is very high internationally, in Europe, and also in Saudi Arabia, as we are going to see. Both the fractures caused by osteoporosis, which are the low energy fractures or fractures from standing, as well as the burden or the DALIs are all increased and has been increasing in the past years. And also as you can see, the fractures caused by osteoporosis are in millions, and the burden of these fractures is very high, both on morbidity and mortality. Most of the, you can see the direct and indirect causes actually of osteoporotic fracture is quite high. Also in Europe, the burden of osteoporosis and the fractures of osteoporosis has been increasing every few years by about 25–27%. So it is on the increase, and especially the disability. And the fragility fractures as well as the osteoporosis, they are in the front line in the disability of non-communicable diseases. So the osteoporosis fracture is the fourth leading, and also the disability in general because of osteoporosis is higher than any cancer except the lung cancer. So it's quite high, and it is actually very important. That's why it's very important to pick up on fragility fractures and treat them and prevent them, actually. So this is just showing you the burden and where does actually the fracture of osteoporosis and hip fractures stand in the burden of non-communicable diseases. Again, in the USA, the cost is in billions, and in Saudi Arabia as well. You can actually, if you consider the cost of osteoporosis without fracture is around $1,000 per case. If you consider the cost of the fractures, it reaches to about $10,000 US dollars, and this is per person per year. So, and this cost actually is increasing in Saudi Arabia. And in Saudi Arabia, it's the same as in the other parts of the world. About 50% of patients with hip fractures, they will not go back to their normals at all. And this is quite high, and this is very important to try to improve in all the programs that we put for prevention. Our one-year mortality in Saudi Arabia is higher than the regional part. It's about 25 to 27%, and this is something I think is of importance because hip fractures are a major cause of mortality in fragility fractures. And if you consider Saudis only over the age of 50, it's still the fractures are predicted to increase actually sevenfold by 2030. So this is actually a very serious problem in the country, which we should really look for treating and preventing. And this is just showing you the cost of fractures, osteoporosis fractures, and some of the parameters that are used for to measure the osteoporosis burden. You can see that the estimated, the fragile fracture estimation is going to jump 130% by 2030. And you can see, of course, the prevalence of osteoporosis 34%. So it is quite high, and it is something that we should all look for. Now, in general, the fragility fracture is a pathological fracture due to a low energy trauma from a standing position or less, or sometimes even without any history of a trauma. So you don't even need to have a trauma to have a fragility fracture. And in addition to that, those patients with osteoporosis, they are more prone to fractures in high energy trauma. So it's not only low energy, but high energy, they're more susceptible to fracture in high energy trauma. So it affects on both sides. And the previous speaker talked about the quality of bone and the strength. It's not only the bone mineral density, it's other criteria in the bone which actually plays a part there. Of course, the fragility fractures in general are more common in spine. The commonest side spine may be followed by the hip, but the hip is the most mortality comes actually with hip fracture, which can reach up to 20%. And the fragile fracture are more in female, definitely about 60%, and the international burden is of fragile fracture in non-communicable diseases is about 0.8%. So you have to bear in mind, and that's why prevention is very important, and that's why early detection is very important. As little as 10% decrease in the bone mass can actually lead to doubling or more of the chance of hip and vertebral fractures. So it is very important again and again to treat and discover this. Of course, the bone or the fragility fractures in all sizes actually increase with the reduction of bone mineral density, as well as other factors, age-independent factors, age by itself, the body mass index, and any history of previous fracture in adulthood. This is just to show you how the trend also in Europe the fractures are increasing, and these are in countries where they have been in the process of all prevention and treatment of osteoporosis for years and years, and still the percentage is really increasing. Now, forearm fractures are important, especially in men. And forearm fractures are a good predictor of future hip fractures in men compared to vertebral fractures in women. So it is important to put in this in mind. You don't ignore, you don't say that, well, it's mainly vertebrae or hip, and you ignore the forearm fractures. It has been shown that it is a good predictor in males of a future hip fracture. So you have to take care of that. And of course, the mortality, these are the factors which affect mortality. And in the USA, about 8% of males and 3% of females, they are prone to die in hospital after hip fracture. And this is quite high. And the disability, about 8% of patients, they do have some sort of disability and continued disability, and they need continued care. So this is important, very important. The Fragility Fracture Network actually have published their call for improvement in several aspects of the care of osteoporosis, especially the ortho-geriatric care, the multidisciplinary care, and the secondary prevention, as we are going to see a while ago. So, vertebral fractures, as we said, vertebral fractures are the most common. But vertebral fractures are a very good indicator also of future vertebral and non-vertebral fractures. So this is important in the management to put in this in mind. The lifetime risk for vertebral fracture is higher in females, and the good thing that actually vertebral fractures can be improved. The secondary or the future vertebral fracture can be improved with the treatment by at least 50%. So treatment is important, and picking it is even more important. It is very common in all over the world, actually. The percentage of underdiagnosis of vertebral fracture and missing vertebral fracture is very high. Only 1/3, as been said in other speeches, only 1/3 of those patients come to clinical attention. And also there is a very high percentage of missed fracture. And to pick up a vertebral fracture, as we are going to talk about in the assessment, you need also a good radiologist of interest in this. So because of the importance of vertebral fracture, it is the most common. It can predict other fractures. It can be prevented, and also the increased number of severity, of course, of fractures. They increase the incidence of future fracture. Because of this, you need to pick it, and you try to pick it by several things. And these are the clinical options that you have. On the top is the vertebral fracture assessment, and this is done either by during the DEXA, doing the DEXA or on radiographs, radiological assessment. And this is considered to be cheap and very effective. Of course, the other thing, if you don't have this facility, then lateral dorsolumbar AP and lateral radiographs is available, CT, MRI, and scans. Now, just to nomenclature, just because we talked about prevalent fractures, when we talk about prevalent and incident fracture, prevalent is a fracture at the time of diagnosed at the baseline, at the time, and incident fractures, any fractures which happen later on. So when we do the assessment, the vertebral fracture assessment, either by X-ray or by DEXA, we use the Geinant method. And the Geinant method actually divides the fracture of the vertebrae to three, either minor, moderate, or severe, depending on the percentage either of an anterior or a middle or posterior fracture. And the mild is around 20 to 25% loss and loss of height, and the moderate is about up to 40, and more than 40 is severe. Now, you do choose points in the vertebrae, anterior, middle, and posterior, and you do compare the height of all of these points. Now, as I said before, you do need a good radiologist and interested radiologist. Of course, this can be done also digitally. There is a digital programming for this in some places. Okay, so when you do this assessment, it's very important for a radiologist to, and for you, to exclude, of course, other causes of loss of height in the vertebrae. It's very important. You don't miss on that. Metastasis, infection, congenital anomalies, all of these. Now, these are some of the indications when do you need to do this assessment or X-ray assessment? And there is two recommendations, either the International Society of Densitometry or the American Osteoporosis Society. The American is more elaborate on the age distribution. Both of them, they use the BMD of -1 or less, and any of those options as a criteria to do your assessment: the age, the loss of height of 4 centimeters or more, prednisolone, and self-reported vertebral fractures, or if you have other risk factors but a normal BMD. So you can use this, or you can use this is the American Osteoporosis one. As you can see, the American categorizes the age in more details, and also uses the T-score in different parts, in any of the either the lumbar, femoral, or actually total hip. So this might be more elaborate, but you'll have to stick one and have a system in your institute or clinic. Now, when you do the assessment, these are the very modalities that we use. As I said, the vertebral fracture assessment with DEXA is considered low cost and low radiation, followed by the radiograph. Of course, the advantage of the radiograph, that is the resolution actually is better, and also it's sharper in the images. Now, you can, if you do have actually DEXA in your hospital or in your clinic, and you have a good radiologist, Okay, you can start with VFA with DEXA. If it's not clear, you do the X-ray. So this is an option. If not, then you do the X-ray. Now the other modalities, the CT, MRI, and scans are used mainly to exclude pathological causes, or if there is actual question of pathological cause of the fracture, and also if there is on the MRI edema, this may indicate the acuity of the trauma, and this may be an indication with severe pain for surgery, as we're going to see. So you may do this, but you will have to be selective and know when to do it. So the management, well, as they said, prevention is better than cure. And the prevention has been shown to be cost effective in this manner, in fragility and vertebral fractures. And you have three categories of prevention, either primary or secondary or tertiary. The primary is to tackle the modifiable risk factors, all the risk factors that you can modify, you tackle them. The secondary is actually this, when you have a low BMD, is this plus all of the following. Pharmacological, of course, treatment, very important to have a fracture liaison service and the fracs. Fall prevention is very important. You do not only do treatment and send the patient home. And orthogeriatric care, and maybe we are lacking in our part of the world of the orthogeriatric. Not a lot of orthopedicians, I'm one of them, have interest in this, but I think it's very important part of the management. And of course, the tertiary prevention is all of this plus a multidisciplinary, and this is what should be the multidisciplinary approach for prevention of vertebral fragility fractures. Now, it has been mentioned, the gaps has been mentioned in the other talks, and this is an important concern in the treatment of fragility fracture. There is a gap in the treatment, there is a gap in the post-traumatic treatment, and also there is a gap in the adherence. And these figures are of Europe, and if these figures in Europe are very high, as you can see, okay, so I would expect that in our part of the world it might be the same or even higher. So these gaps and concerns are important, and that's why even in Europe they failed, even in the post-fracture treatment gap. With all their programs, they failed actually to improve it, except in the UK. So these are important concerns. Now, you can start in vertebral fractures, you can start the treatment for those even without the fracs and the BMD, with those with recent multiple or severe, the grade 2, grade 3, or multiple fractures. When patient presents with this, you can actually start your pharmacological treatment. Sometimes in a grade 1 or doubtful cases, which are in the beginning actually classified as grade 0.5. But in grade 1 with other risk factors, definitely you also start treatment, and that's why it has been told the liaison service, the fracs, all these assessment tools are very important to use. How long? This depends on the medication that you are using. I think that's why the importance of multidisciplinary, that your endocrinologist, your rheumatologist, whoever, you all take a part in the management of the patient. And of course, we know that teriparatide, that has a maximum time, and then it depends on the bisphonates and non-bisphonates. It depends actually, especially in the bisphonates. If you have to take a holiday, then you will reassess the patient and add treatments. So, and of course, as being said in the earlier lectures, the bone forming and the anti-resorptive medication, you have to have also to put in this in mind. Now, when a fracture happens, the non-surgical or non-pharmacological treatment is important, of course, to improve the quality of life. Pain control, rehabilitation, bracing. Now, we don't use bracing except for a short time during the acute stage. Okay, it's good to relieve pain. But you don't really continue for long. And rehabilitation is really a cornerstone in the management of these fractures. Now, in surgery, you do consider surgery within, first of all, if you have a fracture, it has to be early in the first 2 months. And if you did not have a response from medical treatment within 6 weeks. Okay, and your option of surgical treatment is either the kypho and vertebral plasty, or actually instrumentation, surgical instrumentation. Now, the kypho, the difference between, you may know the difference between the kypho and the vertebroplasty. The kyphoplasty is you're injecting the bone cement inside the balloon in the vertebrae, and the vertebroplasty is injecting the cement directly into the vertebrae. They are mainly used in anterior and middle fracture. The problem, if you have a posterior fracture, that actually this will have a high leak. So you consider this, you do it mainly in anterior and middle fractures. And of course, if you have a posterior fracture and you are thinking of using it, you will have definitely to do the MRI and CT to check the posterior canal. Okay, you don't do kypho or vertebroplasty in these patients, anyone with neurological deficit, infection, tumor, allergy, or patient with coagulopathies. Okay, and you may use it as a first line in very frail patients, or patients with long use of steroids and persisting use of steroid. You can use this as a first line. Okay, even before trying or along with other conservative measures. These are some of the complications. Leak is the main complication. The others are less common or actually rare, but leak is important because it can affect neurologically, or it can lead to spinal stenosis. So you have to have this all in mind, and this should be done, of course, by a trained orthopedic surgeon or intervention radiologist. So this really is not for either general orthopedic or occasional orthopedic surgeon. In a recent meta-analysis, it has been shown that actually kyphoplasty is better than vertebroplasty in all kind of parameters, the VAS, the improvement of kyphosis, the improvement of the high, in all aspects actually, and recurrence, the kyphoplasty is superior to the vertebroplasty. Now, the spinal fusion is seldomly used. When do you use it? You use it if you have myelopathy or radiculopathy. Why? The complication actual rate in spinal instrumentation of vertebral fracture is high, is on the average of 50%. And this is very high, and this is usually done by spinal surgeons. But still, it is high, and mainly, of course, one of the very important is the mechanical failure of the implant and the junctional kyphosis, which occurs even with that. Other, of course, complications, revision, perioperative, and new adjacent fracture. So this wraps up our vertebral fractures. It's very important. I think the message that I want to relay that vertebral fracture and fragility fractures, okay, should be picked early, should be treated thoroughly, okay, and you should use, and we should have the other services and modalities that we can predict the risk factors of fragility fracture. Thank you very much.
Thank you very much, Prof. Hazem, for a great presentation. Now we will move to the live discussion and the panel discussion. If you have any questions, we received some questions already from through the SMS, and you can send them through the SMS if you would like. In regard to Prof. Chong, her questions will be postponed. We will try to hold her questions until the next session because of this time difference. I received one question for Prof. Hazem. It's about the acuity of the fracture. How can we differentiate? What are the modalities that you use to differentiate between how acute is the fracture? Because as you mentioned, around 30% of these fractures occur an incidental finding, so we don't know is it acute or chronic.
Yeah, if there is a question actually from the acuity, of course history is very important, and what the patient tells you, the degree of pain, but of course what can differentiate is the MRI. And the edema is in MRI, and the high signal is actually in T2 is actually a predictor of that. And you can use MRI for that reason. But as I said, that most of those fractures they do actually come to the clinic. Sometimes accidentally you discover the fracture for doing an X-ray for any reason. So, but the assessment of acuity, good history, of course, examination, and use of the MRI can tell you about the edema and the increased intake.
We have here a question for Prof. Mikulski. The question, can we use FRAX as a tool for predicting fracture risk for all ages, including younger patients? And if not, what is the age limit for the FRAX use? We cannot hear you, Dr. Mikulski, just wait. Do you fix it? Do you hear me, Dr. Mikulski?
We cannot hear.
Prof. Mikulski, can you hear us?
He can hear us.
Okay. So, so can you respond to the question, please? So still we cannot hear you until we fix the problem. I have another question to Dr. Hazem. So please, if you can proceed with the question, with fixing the problem with Dr. McCluskey. I have a question that I received already regarding vertebral fracture also. Most or commonly seen in the clinic is the single mild vertebral fracture. What to do with those cases?
This is actually a gray area, but if you can, if you don't really, if it is single, accidental, and it's mild, you may follow up the patient. Now, I'm not very happy, you know, in the Arab world in general. Actually, we do lose patients in normal follow-ups. So I think this, you have to use your judgment where the patient is, the education, the level of education of patient, and you have to use, of course, the other modalities. The fracs is of course very important. So I might actually personally treat or ask my endocrinologist, okay, to take his, of course, opinion in that. But I would lean towards treating. But if you follow them, consider follow-up, there's nothing in that. Repeat the X-ray, repeat the assessment. Mind you that the grade 1, the mild, is really difficult to assess. So you do have to have maybe a talk with your radiologist, and then decide if you want to follow up. Then you follow up within a reasonable time, 6 months or so, and assess.
Great. Prof. McCluskey, they are telling that you are muted. If you can unmute yourself, please. So are you with us, Prof. McCluskey? Okay, so we'll wait for him. He will be back after that. And the third question for Prof. Hazem is that you mentioned about high energy vertebral fracture. Does it make any difference? And is there any risk for future fracture with high energy vertebral fracture?
I mentioned just that studies also, because when we talk about the fragility fractures, we talk about actually low energy fractures from standing position, and usually on the side, not even on the front. But yes, I mean, studies also have shown that even patients with osteoporosis, they are more prone to get a fracture from a high energy trauma than ordinary normal people without osteoporosis. Is that the question?
Hopefully they fix the problem with the Prof. McCluskey. So I'm not sure if he's back or not, but answering your question, fracs, and can we use the fracs in younger population? In general, fracs meant for those above age of 40. So it's meant for those above age of 40. You can use the fracs from age 40 until age of 90. You can use the fracs ultimately. We have also another question until we get the answer from Prof. McCluskey, is about what to do in regard of adjustment of diabetes and aromatase inhibitor in the current fracs that we are using here. So until we have his answer, just to highlight that there are meta-analysis that has been done, and what we can do in regard of adjustment of fracs in type 2 diabetes is by either increasing the age. So hopefully he's with us now, Prof. McCluskey.
Still.
Can you unmute yourself, please? Yeah. Anyway, we'll have maybe the second lecture or the third session will be, Prof. McCluskey will be with us, so we'll be holding
If you
these
don't
questions.
mind, yeah, we have a question for Dr. Hazem also. When I can consider a vertebral fracture is a pathological fracture, sometimes said in a CT minimal compression of vertebral fracture, can we consider it is a pathological fractures? It's not a clear question.
He's talking about,
Maybe-
asking about the
I think
pathological,
how to differentiate between.
differentiate on CT.
Yeah, maybe. Or maybe he consider if there is a pathological fracture, is it considered a fragility fracture or not?
Well, pathological,
This question.
of course, vertebral fractures do occur for causes other than osteoporosis, and that's why it's very important. The history is very important. Complete history is very important, and examination. And you can use all the mentioned modalities in differentiation. When we talk about the assessment or using only plain X-ray, this is the first step. But if you have any doubt, of course, you have to use the other modalities. I mean, of course, the scan will tell you about metastasis, increased uptake, which happens also in the acute fractures. This is the question of the acuity. And the MRI and the CT. So, yes, you do use those modalities. Infection, of course, you might, in certain diseases or pathologies, you might have to use contrast with the MRI and CT. Of course, the CT will give you a better picture regarding the bone structure. And of course, the MRI is in cases of metastasis or in case of spinal canal pathology. So in other causes of pathological fracture, yes, you do those, use those modalities. But of course, again and again, history is very important. That's why we say you have to have a very good history. That's part of your clinical assessment, very good examination. And then you can use the modalities as, I think if you need the advice of any colleague, go. And that's why it is important to have a multidisciplinary care and approach for these patients. I'm not sure whether I answered it. Is that?
I think.
Okay.
Thanks, Prof. Hazem. Just back to the question of type 2 diabetes and an adjustment in the FRAX, mention about the meta-analysis of different algorithms that has been used to adjust for that. So the first one, that you can go up with the age by 10 years or by decreasing the T-score of femur neck by -1. The third one was that you can do is by clicking on the rheumatoid arthritis, and the fourth one by adding the TBS value, if you have that. And there was almost comparable in regard of outcome of this TBS, and also increasing the age by 10% was a better predictor for future fracture in patients with type 2 diabetes in general. Prof. McCluskey will not be here with us now, but hopefully in the afternoon session we'll have him. And we'll proceed with the next questions with him at that time. With that, we'll conclude our session, the second session, and we'll meet, inshallah, at 1 p.m. Thank you.
Thank you.